Okay, good afternoon. We have a quorum now, so let's go ahead and get started. And why don't we let's start on an easy one today. How about Senator Tillery?
Thank you, Mr. Chairman. Thank you for your time.
Oh, absolutely. Yeah.
Senate Bill 505. I'm not sure that I have the latest LC number, but y'all may.
I think it's the same one. We're just going to have some amendments.
We're back from the bill you sent over, what we have in our package. Thank you. What we have in our package from 505/FA. Is that what you have, Blake? Senator Tillery?
Let's see here. Okay. Well, I'll talk about the underlying bill and then we'll have some more discussion if you'd like. 505, basically I think it was in 2021 or 2022. I honestly don't remember the year anymore. We provided a bill about, both chambers passed a bill related to transparency in hospital settings and required various postings. I'm sure you recall that. Some of it was over the gnashing of teeth, and turns out that it really hasn't been that much gnashing of teeth since we passed it, possibly because maybe some hospitals are following it better than others. So what we tried to do is go in and provide a form that will be produced by the Department of Community Health to say, hey, here's how you fill out this form that reports the various things we passed several years ago, and talked about how it should appear on your website. If you don't follow, we also put some teeth in. If you don't follow these provisions, then you run the risk of losing your state funding, and so, which could include Medicaid. There have been some discussions about whether or not Medicaid could be included with that. Some folks have said that it can't be. Some people have said that it could be. I'm not here to debate whether or not it could or it couldn't. If you fill out the form and post it like it's supposed to, then that's never going to be an issue anyway. There was an amendment in the Senate that defined community benefit, and that's another discussion point. If you are a nonprofit hospital, one of the things I understand is you have to provide a community benefit, although there's been some discussion about what that word is defined to mean. I don't think it's defined elsewhere in code, so there was a floor amendment in the Senate that provided a definition for community benefit. And it broke it down into two tiers. It said if you're a county over 100,000 people, it means this. If you're a county under 100,000 people, it means something different. Under 100,000 people would mean that you have to offer charity care or government-sponsored indigent care at a level that is reasonable in relation to your community needs as defined through your community needs assessment, which I understand is something that nonprofit hospitals do. If you're over $100,000 people in population, the thought was that your community benefit should be defined as essentially what you save in taxes by being a nonprofit. We didn't want to make that so hard, though, that it was hard to hit. So we excluded the federal income tax portion of that nonprofit benefit. So you essentially would be having to provide charity care or government-sponsored indigent care in an amount equal to or in excess of what you would save if your profits were taxed at the Georgia state income tax rate, which, as you know right now, could be falling.
Okay. Any questions? I think we have a sign-up sheet. I have not seen it. You have one? Okay. Yeah, go ahead.
Chairman Tillery, one question. I think what we're doing here is great because, again, disclosure and all that is transparency is it. Help me because I may be misunderstanding some of the tax implications of nonprofit, but I know we do have some hospitals that they're publicly traded hospitals or private now. From a disclosure point of view, how does that work with this? Are they in here or not? Do they have to make the same disclosures if we have some of those that are providing or in these counties?
Well, I understand there's going to be an amendment that potentially adds folks that are nonprofit hospitals to this disclosure as well. That doesn't bother me a bit. In fact, That is one of the amendments that I understand may be offered that I would support. Disclosure is not a problem. I would ask if we support that one, though, that we take a really hard look at the charity or the community benefit portion. Because if you're going to hold yourself out to be a nonprofit and we don't define what that community benefit means, then we could end up in a situation where having a board that's partially backed by a government entity, maybe the nonprofit piece doesn't really mean that much at all.
Good thought. Good.
Okay. Any more questions? All right, we do have some people signed up. Thank you. I'm sure you'll want to wrap up when this is through. Tim Keebler. Well, I thought you were gonna, well, we haven't had the amendments introduced yet. So I didn't know if you wanna, is that all you want to speak to, our amendments?
Yes, sir.
Okay, we have other people signed up. Does anyone else want to speak other than two amendments? Nope. Okay. Then, do I hear a motion for well, first of all, do I hear a motion on the bill? Do I hear a second? Okay. Do I hear any amendments?
Mr. Chairman, I have one long amendment that I placed in everyone's folder. They had everyone placed in the folder, and it speaks to two things. The first one. Yes, sir. The first one, Mr. Chairman, committee members, deals with the issue that we just kind of touched on there with Chairman Knight. As it relates to having this transparency across the board, I think if it's important for our nonprofits, should have some disclosure for those not hospitals that are for profit. I think and we're not asking for anything too onerous. What we're asking for is simply the 10K annual report that they have to file with the Security and Exchange Commission. This isn't new or duplicative work, so that would be what the amendment does. And secondly, I know we're having there's been this debate about how community benefit is defined, and it wasn't the original underlying bill. It was something that got added as a floor amendment, but I feel like that may be better as a standalone bill and to be debated in a separate measure. I just feel like it's a little complicated, and I also have some concerns with it being a population bill and being unconstitutional. So what I would do is I would strip the community benefit definition out, Mr. Chairman.
Does everyone have the amendment? Do we understand where we are? The top of the amendment says strike lines 17 through 28. We're all on the same page? Okay, go ahead.
And that's simply, Mr. Chairman, the amendment as it walks through, it would strike the language there about the community benefit language, and then also at lines 29, 31 through 31, it talks about that a hospital mean any publicly or privately owned hospital, and that's again that's the essential part is expanding it to all hospitals, while also striking this community benefit language, which I understand need for, but I have concerns about the population bill being unconstitutional. And I think it'd be best for us just to debate that in another form.
Okay.
So that would be my amendment. I would offer that as a motion, Mr. Chairman.
Okay. I'm sorry I had things being handed to me. Have you gone over these last three paragraphs? Are we doing these probably one at a time?
No, sir, Mr. Chairman. I'd offer it all as one amendment, if you'd allow me to.
Offer all these as one amendment?
Yes, sir, Mr. Chairman.
Okay.
And it talks about there at where it says after line 60, that speaks to the form that they already fill out. Where it says line 70, that just strikes nonprofit so that we have this transparency all across the board. And then line 110, where we're striking the community benefit definition, that would just be consistent with that.
Right, just the words community benefit, provide a community benefit. Okay. That's the easiest thing you have on the page. All right. Any questions from anybody on the committee? Representative Knight,
And again, I want to make sure, because
go ahead.
with the definition, and I'm trying to understand this, and I know you said, you know, maybe a separate bill or something different, but I'm not sure. I mean, is this hurting by leaving it in here?
I think first, it being a population bill, it could have constitutional problems. That's one issue I think it has. Second, it wasn't the regional sponsor's original bill and what it was aimed to do. It did get added in the Senate, but I feel like we don't understand necessarily the impact that this would have, and that's why I would just prefer not to have it in this measure. Let's get some of this transparency, get the transparency all across the board, and then let's revisit this issue while also clearing up any constitutional problems it has with the language.
But and further question, if I could, Chairman, if it's the constitutional measure with a population, could we redefine it? Because sometimes we are, historically I've looked at it from a point of view of, we have had, I think, hospitals that are supposed to be doing a lot of, you know, community benefit, but it's hard to tie that in. I'm just wondering if we should go ahead and do something or at this point tie it in. If there's a constitutional issue with the population, could we redefine it in a way that would avoid that argument? And I'm not, again, I just saw this bill coming in, so these are legitimate concerns I have, you know, and if there's a need, and I don't know if that's something that we need to look at and discuss.
I understand, you know, we all want to have we all want to see that benefit that the hospital's providing. I think we'll hear from some of our people who are going to speak to the amendments about the benefits they are providing and how that's policed today through the department. So that was just another one of the reasons for my amendment.
Representative Petrie.
Yeah, Mr. Chairman, all I was going to say, it seems to me that it's reasonable to take out, the focus here is on the transparency, and it seems to me something that could easily be addressed another time as another initiative, but to accomplish the goals that it seems to be from the author, I think you could easily amend this and lose nothing. So I support that.
So you're speaking to all these amendments? Are you talking about just
They all,
the first and all? Oh,
they all
okay.
ultimately address the same issue.
Okay.
Yes.
That's why I wanted to offer them all at once, Mr. Chairman.
All right. Representative Newton.
Thank you, Mr. Chairman. On the regarding the, I guess it's the continuation of the definition of hospital. Is the intent to have this apply not only to publicly owned hospitals, which have a nonprofit status, tax exempt status, but you want it to apply to privately owned? Would the part that you put on section C after line 60, is that your effort to make, would that be the only report a public hospital would have to provide, or is there more detail in?
That would be,
Which is already public.
yeah, right.
So that's really the way you're including the publicly owned, which don't get the same tax benefits that a nonprofit or a hospital authority might get.
That's right.
Okay, thank you.
More transparency and sunshine.
Okay. Mr. Kibley, would you like to speak now?
Yes, sir, Mr. Chairman, if I may. Tim Kibler with the Georgia Alliance of Community Hospitals. I want to apologize for my voice. It's been going in and out all day. Been having a few conversations today. We're here in support of the underlying measure and Representative Kelly's amendments. We had suggested that there was some to speak to Chairman Tillery's original intent was to create information for the patients at Georgia hospitals to have financial information about the institutions where they're being served. And we felt like it made a lot of sense for every Georgia patient to have access to similar information. And while, as Chairman Newton has pointed out, there's sort of a different track, the document that Representative Kelly references in the amendment is publicly available today and would not require the hospitals to come up with some new information to then publish. It is information they're sharing already with the SEC. This would simply make it more accessible to Georgia Georgia patients. Excuse me. We do have a difference with Chairman Tillery on the community benefit language. I think Representative Kelly has spoke eloquently to the constitutional questions. Also, traditionally, community benefits have been essentially the same at the federal level and the state level. This would draw a sharp distinction between what consists as a community benefit at the federal level and at the state level. And it would mean at the state level, things like colorectal screening or other cancer screenings, other blood pressure readings, those things would not be counted as community benefits for our Georgia hospitals. So we have a concern that it would be harmful rather than helpful in the final analysis to Georgia patients and their efforts to be properly screened and prepared for the care that they'll need to receive at the appropriate time. I'm glad to answer any questions if there are any, Mr. Chairman, and would ask the committee to please support Representative Kelly's amendments.
You have no questions.
Thank you very much.
Miss Anna Adams.
Thank you, Mr. Chairman, members of the committee. I'm Anna Adams with the Georgia Hospital Association. I wanted to just share for the record that GHA was supportive to neutral to the underlying bill. We started to have some concerns when the amendment was picked up on the floor related to community benefit. As Mr. Kibler suggested, the definition that's included in this bill for community benefit does not really match with what we have to report to the IRS annually. That's contained in Schedule 9 or Schedule H of the 990 report that hospitals have to file. Many of hospitals' large expenses that go to community benefits, like graduate medical education, free health screenings, things like that, are counted as community benefit per the IRS. But under the definition that's included in this bill right now with the amendment, those would no longer be counted. And so we have some concerns about setting a floor, especially because that number is often inversely proportionate to the amount of uncompensated and charity care that hospitals are providing. So when you have a set margin, the more uncompensated care you have to do, the less funds are available for community benefit, and it works inversely. And so we want to make sure that hospitals are able to use the margin that they have in a way that's responsible for their community. So we think that the department probably has some flexibility as well to dive in a little bit more on this community benefit piece, and we would be open to having further discussion in the future. But we do support removing that amendment from this legislation at this time.
Any questions? Seeing none. Thank you, ma'am.
Thank you.
Roy Robinson.
Yes, sir. Roy Robinson with HCA. My partner, Josh Belafonte, lead
Yep.
counsel for HCA, will address the bill.
Oh, okay.
Thank you, Mr. Chairman, members of the committee. I'm here on behalf of HCA, as Roy pointed out. HCA is a tax-paying health system. In fact, in Georgia, it paid $44.9 million in taxes last year, state and local, and was still providing about the same level of charity and indigent care as those that do not. The community benefits that you just heard about, screenings, graduate medical education, HCA does that as well. Memorial in Savannah is an incredibly significant, large teaching hospital. HCA also provided $139.8 million of charity care, uninsured discounts, and other uncompensated care in the state of Georgia last year alone. So if you're looking to community benefit, that is something that happens. It's in the IRS code. It's the deal made with entities. If you want to be a tax-exempt hospital, you are a charitable institution. In order to be a charitable institution, you have to provide a community benefit. The same community benefits, though, are being provided by your tax-paying hospitals, but they're doing it while paying taxes. It's not anything against tax-exempt hospitals. They're certainly free to do what they want to do. In terms of the disclosure pieces, it is correct that because HCA is investor-owned, there are filings with the SEC that provide much of the information that is currently in the legislation. The problem is, and I don't have the amendment in front of me, so it's difficult for me to see exactly where it is, but the current bill, as I see it, you would be expanding the definition of hospital from the status quo. And then in addition to that, on lines 56 to 60 of the current bill, it says if the hospital is not required to file a Form 990, which is what the tax exempt hospitals do, then the department will establish and provide a form that collects the same information. Well, that gets to be a little difficult sometimes when you're comparing a 990 to an SEC filing. They look at and provide different pieces of information. So in terms of just bringing in the tax-paying hospitals, I don't know that the current language would do it. And I'm not sure what the amendment would do. But yeah, anyone can go look up the SEC filings that are there. So with that in mind, we have HCA is neutral on the bill overall. It's not something, but in terms of bringing in tax-paying hospitals, when they're not required to provide a community benefit, that's the side of doing taxes, even though you can look and see and compare charity and indigent care national studies, including last year's show, many tax-paying hospitals pay more or do more charity and indigent care, $3.86 for every 100 versus $2.89 for tax-exempt hospitals that are not government affiliated. Government affiliated do about 401. That's in Health Journal, peer-reviewed article. So if you want to bring in the tax-paying hospitals, we would ask that it at least be as simple as it is in terms of whether it's the SEC filing, but we would suggest to you that that is unnecessary given that the information is already available, made to public regulators, and in exchange for paying taxes, that's the public policy argument against it.
Okay, you do have a question. Dr. Newton, Representative Newton.
Yeah, thank you for that. And I do agree there's obviously a tax-paying entity, whether it's local property taxes or state income taxes is dramatically different. Now, there is something in state law, though, called Certificate of Need that does theoretically protect you from competition and open up across the street. Do you think there's any obligation, maybe not to the same degree as one who also gets all the tax benefits of income tax protection, city or local tax, property tax, federal as well? Do you think there's any obligation, or should there be any requirement on doing and disclosing community benefit if you're going to be the recipient of protection from competition by itself?
Yeah, I mean, I think the tax code would certainly cover that for the tax exempt folks. In terms of whether CON requires you to do some type of community benefit, what I could point to is that under current law, when there are requirements to provide charity and indigent care as part of obtaining a CON,
Right.
there is no distinction made between hospitals that pay taxes and hospitals that do not. And so, and under licensure law, under Georgia, you have to make a charity and indigent commitment to have a hospital license or an ambulatory surgery license. Those two do not distinguish between tax-exempt hospitals and tax-paying. So you have the same level of commitment, but only one group is paying taxes that help fund the Medicaid piece on top of that.
Of course, in the original, in the original bill on lines 23 and following about the charity care and 100% of the hospital's tax-exempt benefits, which seemed to be the gist of the initial, other than the federal, but just the ones that accrue state and local, seemed to be that was really part of the meat of the description. And of course, those, you're saying that you really don't get a tax benefit from the state or the local. Is that correct? As a for-profit tax-paying?
Correct.
Okay.
Correct. And in fact, looking at the data, HCA facilities, like I said, paid $44.9 million in state and local taxes in Georgia alone. That includes $21.2 in property and sales and use taxes, but provided $139.8 million in charity, indigent, and uninsured discounts. So at least for HCA, and I can't speak to any other hospitals, it is exceeding the standard that is put in the bill as it is.
Okay. Any more questions? Okay, that is all that have signed up.
Thank you.
Mr. Worthy? No, you good? Senator, would you like to come and wrap up?
Thank you again. Thank you, committee. I want to straighten up a few things I think that were said that might be wrong, though. The first is as to the amendment as it relates to the bottom half of the amendment. So I'm going to break it up into two parts. Lines 17 through 28 being the first, I'm going to call it Amendment 1, And then the last part, 29 through 31, we'll call Amendment 2. I know they're all on one amendment. Amendment 2 applies to all hospitals, public and private, if you pass it. And listen to me as I say this. In my district, I have at least 5 nonprofit hospitals and 1 for-profit hospital. So I'm going to make them both mad and say, if the rules are, they should be the same. If you're going to put these restrictions on the nonprofits, you should put them on the for-profits. I'm absolutely cool with the second part of the amendment, strike lines 29 through 31 and everything after that. It's going to put the same burden on both. It's going to be a little tedious for the for-profits to figure out, but that ain't my problem. See, our job here is not to make everybody happy or to make one side or the other happy. Our job is to make sure that the 11 million people who are reading this later, have information that makes sense to them, which is why I think the first part of the amendment, striking lines 17 through 28, is a problem. Let me start with why. This actually was Senator Kim Jackson's amendment originally. So I think she had a point when she brought it. The reason she wanted to bring it is she thought that community benefit was different in different hospitals. And I hate to start saying hospitals' names, and when you do this, you run the risk of killing yourself in the amendment process. But if Grady's stabbing people in the arms and giving them immunizations as a community benefit, and another entity is passing out koozies or frisbees as a community benefit, those things aren't equal. So in one, it seems more marketing becomes community benefit, and in the other, it seems more healthcare becomes community benefit. So I think that's why she dropped this amendment. I think it makes a lot of sense. So I would ask the committee, I understand I'm in a House committee, and you pick, I don't pick. But I would ask you to reject the amendment that strikes lines 17 through 28 and accept the rest, because that does create a level playing field among both. Thank you, Mr. Chairman.
Yes, sir. Representative Newton.
Thank you, and thank you, Chairman Tillery. Do you believe that those lines 17 through 28 adequately differentiate the two very different examples you gave? Do you think we have enough specificity? Number one, when they report charity care, at least we learned in our CON study committee that they report the list price, which is 3 to 8 times what Medicare would pay, 4 or 5 times what a commercial payer might pay. This doesn't seem to get into that difference. I think you correctly said one's marketing and one's community benefit. Do you think this amendment is strong enough? I'm sorry, the language in community benefit is strong enough?
I would have written it stronger, but I don't think that's the way the committee wants to go. I do think that this is a lukewarm approach to the issue, and I think Senator Jackson did a great job for her move on the floor.
Okay. I see no more questions. Do I see or hear a motion on the amendment?
I move to pass.
Do I hear a second? Well, we got a motion on the floor right now on the table. Second? Okay. All those in favor say aye. Aye. All those opposed? Okay, 1 no, the rest ayes? You said no? 2 noes, rest ayes. Amendment passes. Now to the main body or the bill. All those in favor of the bill say aye. Aye. All those opposed? Bill passes.
Thank you, Mr.
Congratulations.
Thank you.
I think. All right, Senate Bill 455, Senator Strickland. Who is your House member?
Blake.
Blake?
I think it was Trey Kelly, I believe.
Don't know.
I know. Oh, who is your House? Who's carrying this in the House?
I would ask Representative Knight if you don't mind.
You good?
Thank you so much.
All right. All right. Senator Strickland, you got the floor. We are on LC 520507 SCS.
Mr. Chairman, I'm fully familiar with the Senator's bill. I move to pass.
I think we're going to let him talk a
I
little bit.
don't have to say anything else.
We also have an amendment for this bill.
Thank you, Mr. Chairman, members of the committee. I know there's an amendment. I'll speak on the underlying bill itself. This hopefully will be a simple one. This comes from DCH, and this deals with Medicaid eligible individuals and third-party payers that are paying part of what is being billed for someone that's eligible for Medicaid. And the bill simply is a cleanup in response to federal law that says we have to now have two things in our code in order to be in federal compliance. One is that we have to be clear that a third-party payer can't refuse to pay for a healthcare item or service solely on the sole basis that they did not authorize the service or item. In other words, the state authorization, since we're under Medicaid, is what's going to suffice, not a third-party payer's authorization. Second thing we're required to do, the bill does, is says that a third-party payer must respond to the department within 60 days under any inquiries that come in under this. That's all this bill is going to do. Mr. Chairman, happy to answer any questions.
Okay, I think people are sort of looking at the bill right now. Do we have any questions? Okay. Do I hear a second? Okay. We do have an amendment. It's in your package. I will speak to the amendment, and it just came in pretty late today. As you know, we've had a bill, 1363, that dealt with some of the issues with the pharmacy payments to our independent pharmacists. This is more of a critical mass. We're losing these independent pharmacists by the week, by the month. And this really troubles me. I mean, this is a free country, and these are the people that I go to church with that are coaching teams of my kids and all your kids, and all they're doing is trying to survive and have equal payment for the very same drugs that the box stores are getting. So this amendment that you're holding right here, essentially, if you look at line 11, it actually what it's doing, and you can read from 11 to all the way to 19, it's really cutting out the study committee or study group that was in the original part of the bill. And you'll see on the back page it goes on to line 22. So the sponsor here, Senator Strickland, has been very kind and gracious to allow us to amend this bill. Do I have any questions on the amendment? Do I hear a motion? Do I hear a second? All those in favor of the amendment? Aye. All those in favor of Bill 455, say aye. All those opposed? The bill passes. Congratulations, Senator, and thank you for allowing us to put this amendment with your bill. Who is your House sponsor?
Do not have anyone yet. Somebody want to volunteer? The chairman? There's lots of chairmen. What's that mean?
Okay, I'll sponsor your bill.
Thank you.
I'll carry your bill.
And Senator Hatchett's downstairs, and House Judy told me to send his regards. We're going to swap places if you want me to send him up here. I think he's on your agenda as well. So I'll tell him to come on up if
Can
you'd
you
like.
text him?
I'll text him now.
All right.
Thank you.
While we're waiting, we've got another bill, and I cannot remember who this, or is it resolution? Whose resolution is it? It's a good one. Somebody. Representative Newton, your resolution.
Thank you, Mr. Chairman.
1231.
Yes, I do bring House HR 1231 LC 339637. I guess we can do this as a hearing only unless you want to have a vote. I'll leave that up to the chairman. But let me just explain a little bit to begin with. This bill has its, number one, there is an amendment that should be in your packet that I hope the chairman will allow to be added regarding adding trauma to this group of areas that are in critical need in Georgia. It would include trauma, prenatal, maternal, and pediatric care. What I want to look at, what I would like us to look at, is the funding on how these occur now and how it might occur under different scenarios. Those are incredibly difficult ones. I'm going to list off a few ways we help cover health care now. There's provider fees, which some people know is a bed tax, and we get super speeder fees. We get a DPP program. I might ask for show of hands who know what the DPP program is or can explain the waterfall program that Kaylee Noggle explained to us last year, the directed payment program that talks about teaching hospitals. We've got DISH programs, disproportionate share programs. We've got some roles for Medicaid CMOs and other insurance company sources. We just talked about charity care and certificate of need and obligations on for-profit entities, but also ASCs, but also on not-for-profit hospitals. And finally, the last thing that I'd like the committee to be able to study in more depth would include, we've got a Medicaid waiver program now. We have a 1332 waiver program right now. Some facilities benefit better by the 1332 than others. In particular, we're looking at potential amendments to our current 1115 waiver, which is currently scheduled to expire in September of 2025. So that doesn't give us very long to look at it. And one of the things we're looking at is the amount of money with different waiver systems that might come in from the federal government, how much would be required in the first 2 years from the state government, how much would be required in years beyond that if we were to look at alternative amendment programs. When you put all those together, it makes it almost impossible during 40 days of session for anyone to get a good, solid grip and analysis of how are we funding it now, and also how might we fund it in the future, especially choosing different options. I think that by having a study committee to look at that, of people willing to dig in, get the relative amounts. I mean, some of these are probably less than 1% of the funding we do for health care. Some of them might be upwards of 20, 30% of how we fund. One of these programs might fund health care, teaching hospitals and all. So I just thought that it would be helpful if a subgroup of the health committee could look at this with more depth, could look at it in a very controlled area, and then could also look at, well, who would the winners and losers be if we looked at different alternatives for uninsured coverage, whether through charity care, CON, or any other 1115 waiver or something like that. And if so, are there some winners and losers that could we set up a program where everybody wins and the only difference is some win some and some win a little more? That would kind of be a goal to see, is there a way we can look at funding and a way to do that? So that's the desire for the study committee. The rest of it is pretty straightforward, like all our study committees on the House side. So that's my background on it.
Representative Kelly.
Thank you, Mr. Chairman. I have no issue with studying this. It's an important issue, certainly. I was just trying to figure out how this study committee would interact with the legislation that Lauren Daniel passed earlier this year about maternal mortality and how those two will line up together.
There is, obviously there's overlap if you have study committees. I think that one was obviously focused just on prenatal and maternal care. This is really to look more at how funding affects access, whether it's in the rural areas, our underserved areas, safety net hospitals, things like that, our teaching hospitals, the different roles. If anybody remembers, the directed payment program was different for Grady and MCG than about 40 other hospitals that do teaching, and then some on the lowest end that had the most indigent care across much of rural Georgia. So that was a program that was tremendous in itself. The DISH program is important. It wouldn't really conflict at all. This is really trying to look at what are the sources currently and what could the sources be on how to fund advancements that might raise the entire tide for all healthcare providers in Georgia.
Okay. Do I hear a motion? Second? All those in favor? Oh, I'm sorry. Yeah, yeah, you got an amendment, sorry.
Oh,
Speak
I'm
to your
sorry.
amendment.
The amendment, I don't know if I can offer the amendment. I guess I'm on
Yeah,
the committee.
yeah.
I'm sorry. Yes, on the amendment, AM 332059, it said to add the word trauma before maternal on lines 1 and 16. And that's just a recognition that trauma is the leading cause of death. We know the maternal mortalities and prenatal care are crucial. You know, pediatric care is crucial. But really all across Georgia, we've heard about in our appropriations and other areas on how we're funding our trauma network and the way it saves lives, especially for those under 45. We thought that adding trauma to this was an adequate thing.
Okay.
Can I ask you a question first?
At request of the author, this is a hearing only. Okay? All right. Now, you're welcome. Next to the next measure, Senate Bill 515, Senator Hatchett. Yeah.
Thank you, Mr. Chairman, members of the committee. Today I bring you Senate Bill 515. This is actually a bill that was in response to a study committee that we had in the off season that dealt with rural health care and recruiting and retaining medical professionals in rural areas. What this does is it looks at EMS specifically, but it's going to have, hopefully will have implications beyond just EMS. It's a 2-year pilot program that provides ambulances in Regions 2 and Region 8 in the state, which are Northeast Georgia and Southwest Georgia. They happen to be the ones that are in most need. But essentially, during our study committee, we found out that one of the biggest issues is wall time. So when a ambulance brings a patient to a hospital, they have to stay with that patient until that patient is admitted into the ER. And so when they're standing in the hall waiting to get in, that's considered wall time. And wall time can be, 0 or it can be several hours. The issue that we heard was, well, the reason we can't bring them into the ER is because the ER is full. The reason the ER is full is because we can't admit patients from the ER into the main hospital or into the inpatient. The reason the inpatient's full is because we've got patients that have received treatment that we need to transfer either back to a nursing home or to another facility. Well, in order to transfer them, you need EMS. And so it's kind of a rock, paper, scissors issue. And so what this pilot program aims to do is, number one, help resolve that issue by allowing these ambulances to move patients from one facility to another facility. The second thing that it will do is it'll provide backup services for if you're in a rural area and you take a patient from, let's say, Towns County, Hiawassee, down to Atlanta. Well, you're just, if that ambulance leaves, once it leaves Towns County, that county's down an ambulance for 6 hours until the ambulance can make it back. So what this would do is, when an ambulance takes off, this pilot program will have an ambulance come in and fill and cover for that ambulance until it comes back. And there will be an ambulance in each of the 2 regions. And the third thing that it aims to do is when you have a flight crew, a flight paramedic crew, when there's inclement weather or if there's issues with the helicopter, for example, that crew is essentially grounded and is of no benefit to the public unless their helicopter can fly. This would also provide an ambulance to air ambulances so that when their helicopter is grounded, they could actually just use a truck for the time being. So it's basically in 3 different ways trying to assist EMS and help lessen the burden that they're feeling at the hospital with the air ambulances and when they're running patients to on long distance routes. There's a fiscal note with this, which is about $4.1 million. I'm working my best to get the this in the budget in the Senate. If y'all have any ends with the House Appropriations Chair, please let me know. I need to talk to him as well.
Are you having problems?
You got his
Uncle Matt?
office phone number? Yeah. But that's right. But no, it's I think it's a good bill, and a lot of work went into kind of pinpointing these issues, and would greatly appreciate your favorable consideration.
Okay, we've got an amendment. Are you going to be suggesting or moving the amendment forward about line 48 with the 2 years after the pilot program?
Yes, and thank you for bringing this to my attention on last week as well. Just in case we are unable to get the funding in, I think by changing that to 2028, that gives us a little bit more time. Doesn't mean we have to wait a year, But if we have to, it'll at least keep this pilot program alive. So you're talking about changing it from 2027 to 2028, Mr. Chairman?
Yes.
Yes, I would be in favor of that amendment if someone would offer it for me.
Okay. I will do that, but let's check and see which LC we're working from. Would you read your LC number off?
Yes, the one I have, well, it's SB 15 CSFA. So I may not have the right one. Okay, that's the one. SB 15 CSFA.
Okay, all right. Let me just check something, make sure we got. 148. Okay. So you want to change then on line 48, 7 to 8? Is that correct?
Yes, Mr. Chairman.
Okay. I have this other amendment that I was given. On 48, after 2 years of the pilot start date, is that in the bill or not? I don't see that in there. Did you want that in there also?
Sorry, you said after 2 years.
Yeah, you on, the amendment I've got is delete the 2027 and replace it with 2 years after the pilot start date. And then on line 29, delete on such date, 49, and delete on such date and replace with June 30, 20, and that would be the change to 28.
28.
See what I'm saying? Senator Atchison?
Yes, Mr. Chairman. I think that accomplishes what we're trying to accomplish, just in case the funding is not there.
Right, and, okay.
Yep.
So if everybody, does everybody follow what I'm talking about? The two line changes? Okay, on line 48, delete June 30th, 2027 and replace it with after 2 years of the pilot start date. Then if he does not get the funding from Uncle Matt this year, then we'll need to change in on line 49 on such date to we'll replace that with June 30, 2028. 28. He'll need 2 years. We're in 25 right now. I'm sorry, what? What do you have in your? Yeah, we're changing that 27 to 28. That'll be changed to 8. The amendment you've got has got 27. We're changing that to 28. We're amending the amendment. And I apologize, but we weren't sure where this was going to be until when he walked in.
That's right.
Okay. Now, I've got questions blinking. Are the questions to the amendment? Huh? Excuse me?
My question is to the bill.
Okay, all right. Representative Parsons.
Thank you. Thank you, Senator. I'm just, mine is just more a little confusion, I guess. The pilot program would be executed with the thought that it would be continued, obviously. I mean, it'd be the hope. Is that correct?
That's
I mean,
correct.
Obviously correct. I'm confused about having a pilot program where there is appropriations and procurement and operation of 4 ambulances. What I mean, so if the pilot program doesn't work out, we've made this commitment and appropriation and expense from the states, but it's for something that didn't. I mean, by the very nature of the bill, it's a pilot program that didn't work out. So we put money into this. I mean, I don't mean to be speaking negatively of your bill. I mean, I'm sure that, you know. I mean, it's with the idea that it will, after a two-year pilot program, it would be going ahead with. So why is it a pilot program anyway? I guess that's my question. Why wouldn't it be a program, and then we would get these? I mean, do you think it would be successful? I mean, why would it just be a 2-year? I'm missing something here. I'm sorry.
Hey, if you want to make an amendment to put it in permanently, I'd be all for it, honestly.
Well, I'm just wondering why it would be that way. I mean,
Well, I think what it is this hasn't been done before, and so in response to our study committee, what we're trying to do is, fix the issues of wait times on the walls and fix issues of having to be down in ambulance in certain areas
Yeah.
and then helping out the air ambulances. Right now, we're only doing it in 2 regions, just because of the funding. And I think if it's successful, if we're able to decrease wall times, if we're able to assist local EMSs that do have an ambulance down, if it's a successful program, I would love to, work on making it not just in 2 regions, but all regions, and be a
Yeah.
permanent thing with the state. But I think I agree with you. I have full faith that this is going to be successful, and we'll hopefully have a permanent place in the state moving forward. But for now, this is kind of the first bite at the apple.
Okay, I mean, I'll support your bill. It just seems strange to me that it's a 2-year program, but yet we're putting money into it with the thought that it may not be successful. But I understand what you're saying. I support your bill. I'm just trying to understand it better. Thank you.
Thank you.
Okay. Representative Sharper.
Thank you, Chairman. Quick question for you. Thank you for the bill. Who would be basically responsible for this staff? Who would they actually work for as paramedics and EMTs?
So what we would do is the Georgia Trauma Care Network Commission and the State Office of EMS. They're going to get together, and they're actually going to bid out the contracts for. If you're in a region of 13 counties, someone that provides EMS to those counties would actually bid and win the contract for to provide the additional ambulance, and they would be, ideally stationed in a central location, and they could, deploy rapidly when needed, depending upon where they are needed in the region. But they would work for the company that wins the bid, whether it's a county-run EMS or a private EMS.
Okay, because I just wanted to know. I was making sure that, I knew that somebody would have to do it, and we were not going to be, hiring staff as a state in a sense to do this. So to be bidded out, and if we're able to make this happen, let's just say you have the 2 in the Northeast and the 2 in the Southeast. If this works, are we going to try to go back to the state again, DPH and everything, and say, okay, we see this working in this area. Now we need 10 ambulances. Now, do you think from a state standpoint we should fund this, or we look at where most cities allow the counties to determine who's going to do the ambulance services in their different areas? Because as you look at it, even though you have the hospitals that are involved here, if you have a hospital, let's say 2 big hospitals in the same city, even if you have an ambulance that can go ahead and say, we're sending this patient here, send that patient there, and you got the wall time, what's going to determine which hospital really gets the opportunity to say which ambulance is going to help be relieved first off the wall time?
Yeah, so I think when we first set out to do this, our idea was to have the state purchase an ambulance and have it be a state-run program. But after working with the Trauma Commission and Georgia EMS, we kind of came up with the idea that we should allow someone who's already providing EMS services in these regions, because like in Region 2, there are multiple EMS providers. Go ahead and let someone who's already there run the ambulance, and then you would just contract with them and pay them from the state. We found that to be the best route. If this is successful, we could continue to contract with local EMS, or eventually we may have a state-run EMS program if this is successful. But for now, we just thought it would be best to contract with those that are already in the regions.
All right, last question, follow-up. All right, who is going to be overseeing the watchdog of, if we're going to give your company a certain amount of money, if you're ambulance service, and we're going to give you a certain amount of money to make sure that you're there to help with this wall time and staff the people, how are we going to be sure that they're not just going to get the money and running their own calls and trying to get the wall time decreased whenever they can?
Well, we have had several meetings with the Trauma Commission and the state EMS office, who are going to be working together, and I think more than anything, one of the products that we're going to get from this pilot program is the data.
Okay.
Both of them are very interested in the data, and I think because of that joint interest and the conversations that we had, I think it will be closely monitored.
Okay, good. I mean, just making sure that we can get those stats and the data is going to be very important to make sure we see the decrease of wall time with these units, and then go from there. But I mean, I think it's a good idea, but in reality, we got to make sure that the accountability is there, and making sure we actually seeing a drop in the wall time. But there's other factors in what area you're in, for as injuries and just overall bigger pictures of possible more people getting hurt, doing different things, and you may not have that wall time decrease, you think, but it's not because the ambulances weren't there to be where they need to be. It was just maybe an increase in that particular hospital's amount of patients and everything. So that data is going to be critical in several different ways.
Representative Newton.
Thank you, Mr. Chairman. I appreciate the effort to try to look at a very real description you did of this reverse waterfall or vicious cycle we get into with inability to release EMS. 2 questions on the bill I have. You've got the 4 units, 1 dedicated to air ambulance, 1 for interfacility transfers, and then 1 for each of the regions. Is it understood that out of line 26 and 29, one of those will go to one region and one will go to the other, because you're obviously at different corners of the state on Region 2 and Region 8, correct?
Yes.
So that's one question. The second one would begin at the end of line 33, where it says each ambulance shall also be used, because I can imagine there's a good bit of time where the air ambulance dedicated one would not be getting used, who would be open then to all that's listed on the end of line 33 and following for critical and specialty care transports, other priorities, non-emergency transfers, even to exit the hospital to a skilled nursing facility, for example. Does that line 33 and before, does it apply to number 1 and number 2 as well? Or is it only meant to apply to the ambulances listed in line 31?
It should apply to all.
Okay, so that was one question, and then the other is, does one region get the time-sensitive interfacility transfers on line 29, and the other region would get their second ambulance would be to back up air ambulance crew?
So I think it's 1 unit shall be dedicated to air ambulance crew, 1 unit should be dedicated to...
I am correct that 2 is northeast Georgia and 8 is southwest Georgia. Is that?
That is correct.
Somebody who, if that, okay.
Yep.
Just kind of a clarification thing.
Southwest, yeah.
On maybe a little better way to say which 2 go here, which 2 go here. And I guess the final thing is what about ambulances do charge, and they do have revenue. For example, I don't know, I assume that's where the bid process would come in, and that's your goal, I guess, is to allow the bid process for them to estimate what their revenue is going to be, their net revenue, and then what their expenses are, and obviously we're going to support the difference. Once again, you kind of need to know where are they going. If it's 2 here in northeast and 2 in southwest.
Yeah, that's my understanding, is that it would be 2 and 2. I see what you're asking about with the air ambulance, and I can get that answer to you.
I would expect they wouldn't be busy today because nobody's grounded. But
Right,
3
right.
days ago, everybody might have been grounded, so they might have been really busy. But so I look at that and go, they need, if they are responsible for revenue, they're going to want to make sure that if they're getting to keep their revenue, which I assume is the understanding.
Yeah, and obviously the ultimate goal is to lessen the burden on EMS, and so we want to maximize the use of all of these ambulances. And so, yeah, like you said, on a sunny day like this, I think.
Not many grounded.
That's right.
Hang on, I'm going to take over here just a second.
Yeah. Thank you, Chairman. Senator Hatchett, thank you for the bill. Wanted to mention a couple of things just in the broader context. So this issue with wall time is a real issue in Chatham County right now. This is something, I've been in healthcare my whole career. And up until a year or so ago, I never heard about these kind of problems to the degree we're having them today. And so this is a huge issue at home. I have a constituent recently that was in her 80s, someone I know quite well, fell in the rain, in the cold, was there for 8 hours. When they found her, it took them 2 hours to get there after they called 911. And the excuse was wall time. This, we can't get out. So my point to all of us would be, there's a bigger issue here we've got to address. We've got to discover a way, and I'm looking over at my seatmate and good friend over there who knows more about this, and certainly most of us here. But we've got to discover a way to find a way to get those folks right back out on the street doing what they do, because it seems like with the staffing shortages in the hospitals, you know, that's what's created this, as I understand it. But it's a real problem where I'm at, and so I'm all for helping, especially in areas where there may be a dearth of providers. We were just discussing some of that, how some areas have such a dearth of providers, so I'm supportive of that. It is unusual to, you know, we expect these to be local services usually, and part of municipalities, counties, not a state service, but I'm certainly supportive of us doing anything we can to make sure people get care as promptly as they need it. But I think we need to look at broader solutions going forward, Mr. Chairman. Thank you. 2 hours.
Thank you, Chairman Petrie. There was quite a few questions, I guess, in there. I didn't know if you wanted to speak to any of them, or did anyone else want to speak to any of the questions that were raised, or no one signed up for or against the bill. We did have the amendments to discuss, but I think the next step to move forward would be a motion and a second on the underlying bill. Do I hear a motion on Senate Bill 515? So we have a motion and a second. Chairman Hawkins going to do the amendments. We do have a motion and a second on the underlying bill, and we did have, Chairman Hawkins had brought proposed amendments for line 48 and lines 49, and in both of those,
Line 49 was changed.
So the line 49 should now read, where's Ledge Council? Can you tell me how, it should end in 2028, is that correct? So then the two amendments would be line 48 delete June 30th, 2027, and replace with, quote, after 2 years of the pilot's start date. And line 49 would delete the words on such date and replace them with June 30, 2028. That's the proposed amendment. I'll offer that amendment if there's so we have an amendment, motion and a second. Is there any concern from the author?
No,
So those are the two amendments proposed. We'll vote on those. We got a motion and a second. Any all in favor of the amendment? Any opposed? Okay, so now we have the underlying bill as amended. Is there any other discussion on the underlying bill, SB 515? If not, all in favor say aye. Aye. Any opposed, no. Bill passes as amended. Thank you, sir.
Thank y'all.
House sponsor.
Senator Hatchett, do you have a House sponsor? Seabass. Thank you, Chairman. Okay, thank you, guys. We're all adjourned. Thank you.
You're right. State's got 16 billion surplus. What's Hillary upset about? What's the deal?
He's not upset.
Of course I love it. I just vote against something I did.
No, vote.
You did vote with the chairman. You voted with Chuck Martin.
We got
It's
four
okay.
more, don't we?
It's okay. I'll pass. 57.
Hey, after 91, it's just they get.